Oh, yeah. So I'm happy to introduce Kassie Jadin, who I met in Oklahoma City a few months ago. We went to a conference on substance abuse that was sponsored by faculty at the University of Oklahoma. And so met a lot of people there. And Kassie was there along with a few other people from the PCAP program and from Washington. And so we subsequently had discussions and so I asked Kassie if if who lives in Thurston County, I mean, doesn't live in Thurston County, but works in Thurston and Lewis counties, if she would talk today about the PCAP program, which has been around this state for a while, since the 1990s, and is very, if you go to other places in the country, it's really exceptional to have a program of this type at this scale. And so Kassie's going to talk about the program today and give everyone a chance to make comments or ask questions there. So, Kassie.
Great, thank you. Yeah, so my name is Kassie Jadin. I'm the clinical director for the Parent-Child Assistance Program for Thurston, Mason, Lewis County. We do have over 15 sites that cover about 20 counties in Washington state. So I think almost everybody who said that they were here, Island County is the only one I'm not sure if they have or not. So I'm going to have to do some research on that. But everybody else, I heard Kitsap, and you guys have fantastic PCAP sites in your county. And if you want, I'm happy to connect you to. So the PCAP is the Parent-Child Assistance Program. And really, we're here just implementing community intervention with families who are at risk. The idea is just that we're really taking the theoretical concepts, research, evidence-based, and experience, and putting it together to make a really functional model that helps families long-term basis. So our program is 3 years. So as long as the client is, sorry, I'm gonna put another time to hear that. I'm remotely today, and my dogs decided, of course, for the first time today to be awake. So anyways, we are 3 programs. So our case managers connect with their clients and are working in home with them for 3 years. Most DCYF cases, dependencies, treatment, anything like that, most of them don't go beyond a year. And addiction and change is really a long-term, program or plan. We kind of have expecting people to change within 90 days or within a timeline, and it's just really not how it works. And a lot of times what we see when dependencies or services even is that they get a lot of help and a lot of support, and then everybody disappears at the same time, and we expect them to stay at the baseline where they were when they had a lot of support. So our program specifically works through that 3 years to help our clients to set goals. It is a client-based program, so it's completely voluntary. We cannot, well, I mean, I suppose you could be court-ordered, but we generally tell people if they're court-ordered or required, that it's not really how the program works, and it's not outcomes that work. When you're told that you have to do something, it's really less effective than choosing to do something for yourself. That being said, our program, we are completely non-associated with any sort of social service departments, DCYF, DSHS. We are not affiliated with anybody. We do work with them if the clients want us to. So just briefly go over a little bit, our clients that we enroll is technically mom. A lot of times people kind of go, well, why are you focusing just on mom if we're worried about the children who are being affected? What we do know is that really the best thing for kids playing that is 0 to 3 is that it's important for them to have stable relationships with family members. So in order to keep those kiddos stable, we want to keep moms stable. I will give a disclaimer. I have been working for the last year trying to expand our program in Washington State to include fathers, because I think we need equitable services there. But currently, we're only enrolling moms, and they must be pregnant or postpartum up to 3 years. So if they have a kiddo that's 5 and they're not pregnant, it's pretty difficult to get them in the program. That's something that we have to go through UW to get an exception for. That being said, the only real requirement for being in the program is the client has to self-disclose some sort of substance use during pregnancy. That includes marijuana. That includes medical marijuana. It includes alcohol. It includes any sort of MAT treatment. So if it's a prescription, like if they're on methadone or Suboxone, even if it's prescription and they're taking it as recommended, that still qualifies. Because what we know is, one, prenatal substance use for a baby can always immediately put us at risk. Not necessarily any other reasons, but that we know that development can be more difficult and often environments are more difficult. But also, if it is a substance use that's not being taken in the way it's supposed to, or is an illegal substance, obviously, we want to work with those moms so we can get them the treatment and help that they need. So really anybody can make a referral. You don't have to be a social worker. You don't have to be in the court. We have clients who refer themselves. We have clients who refer friends. Basically, the only thing we don't do is we don't do cold calls. So you can't call and say, hey, this person probably needs your help, give them a call. But if you are working with a family and you tell them about the program, hey, we can get you connected to a case manager who's going to do, home visits and help you kind of reach any goals you want. Is it okay that they give you a call? And they say yes. All you got to do is give us a name and a phone number, and we can call them and kind of walk them through what that all looks like and see if they qualify for the program. So really, a lot of times, especially I would say some with social workers, often people feel like our program is a little bit of enabling. And there really is a reason for that. Being a 3-year program, we know how the stages of changes work. We know how different everybody is in their needs and their learning ability, and their addiction. So the first year really does look kind of like the PCAP case manager might be carrying them, because honestly, sometimes that's what people need in that moment. So they might be giving them rides to appointments. They might call and remind them the night before that they've got court the next day. They might be like, hey, do you've got your diapers and your kids' snacks and everything for your visit? And that is really because what we're doing in that moment is we're role modeling for them that these are things you need to be thinking about ahead of time. We're here to support you. And they're learning. They're learning that someone is showing up for them. They're learning that somebody cares without any real repercussions. You do not get kicked out of our program. So you can relapse 50 times and we're still going to be there, because what we do know is that relapse is a pretty reoccurring or regular thing in addiction. As much as we want to all think that it's not, temptation is there. Especially, I'll be honest, most of our clients who come in with alcohol as their substance, it's a whole nother process. We really struggle with people who use alcohol because it's so accessible and it's so just socially accepted. So we know that it's not going to be helpful to kick them out of our program. Then what? Then they've got nobody and we're right back to where we started. So we really work on making sure that we are not a punitive program. You relapsed? Okay, great that you told me. Our kiddo's safe. Where were the kids at when you relapsed? What did you do? Were you being protective? Did you know you were going to relapse and maybe the kids went to grandparents' house? So all of those things are things that we try really hard to stay connected with them in that first year. And sometimes it can be 2 or 3 times a week. Sometimes it can be, once a week. Our clients are all very, very different in their needs. Many of our clients come into our program have very, very significant past history of trauma, cognitive disabilities. We have 87% of our clients have one or both of their parents who have substance use disorders. So they're already grew up in an environment where this is this is normal, this is what our parents do. And our parents are our primary role models, right? That's who we learn from when we're little. 65% of our clients, who I would say are probably your clients, right? Mutual clients, were physically or sexually abused as a child. So 65% of them. About 35% were involved with CPS or in foster care as a child. So this isn't a group of people who have just kind of gotten to a bad spot and now all of a sudden are in this, cycle of addiction. This is, they grew up in this environment. This is what's normal to them. This is how they have learned to cope or survive. Our average ACE score is about a 6. And about 40% of them didn't complete high school or don't have high school diplomas. So if you really kind of think about those numbers alone put you just in a category of high risk lifestyles. And really when we think about it, when we're talking about physical abuse, sexual abuse, parents who have substance use disorders, being in the system as a child, not having a high school education, the amount of trauma and just, really continuous trauma that these moms have been through. A lot of times, by the time they get involved with the department or even just, voluntary services, these moms have been through so much, they don't trust anybody. And they're certainly not going to trust somebody who says, we're going to remove your kiddos from you. So within that first year, our goal is just to build a relationship with them, role model for them, work with them and support them. We kind of tell them that we're like somewhere between, your cheerleader and your, time management coordinator and your teacher. It really, really depends. But that first year looks like us just walking them through. By the second year, our plan is really, hopefully we're just kind of holding hands. We're walking together. They've got the experience. They've kind of seen how we've done it. Now in the second year, it's, let me see you do it. What are you going to do when I'm not here in 2 years? So that often looks like we'll make the calls together. We will figure out how to, 1 second, please. Sorry. We will, figure out, you have to do a review for your food stamps. Let's do that together. You call, I'll be here in case you need help. So really it's that model of relationship and teaching them. What I would say most of us think is common sense, or like, I don't know how to do it, but I'll call and kind of figure it out. Those are not things that we just innately kind of knew. Those are things that we were taught. Those are problem solving skills that we learned. And when you live as a child, developing and growing in an environment that is chaotic and unsafe, and I would say our average is about 8th grade, 8th to 9th grade, for those that don't have a high school diploma. And most of them, parents have some issues, so they were generally exposed to substances in utero themselves. So delays, learning disabilities, those are all really, really normal things for our clients. So something that seems super simple, going and paying a bill or filling out a rental application, it's really difficult. And when you kind of take that a step further, when someone shows up and says that your children are at risk and we're going to remove them, and here's a bunch of paperwork, please read it. Do you understand what we're saying? Most people just shake their head and say yes, even though they have no idea what's actually happening. I can tell you, I was a case manager for 4 years before I came into the director role for my program. So I've been there for almost 8 years. When I started and someone started using all of the acronyms that we use for the system and for services, I had no idea. I was totally lost. We use words that are not, a dependency. If you didn't work in the system, you have no idea what that means, right? In-home dependency, all of those type of things are really, really confusing and scary and are not really made for somebody who maybe has an 8th grade education or some cognitive delays. So within that 2nd year, we are just walking them through. This is how we're, and really encouraging them. And by that 3rd year, ideally, they're running on their own. We're here for support. We're here for backup. Things come up. A large portion of our clients, by the time they're hitting that 3rd year, we've graduated treatment, hopefully have housing. We are we going to get a job? If you've got a significant disability, maybe through disability or Social Security. So we really work with them so that long-term, after everybody is out of their life, they have those supports. So I really love this program. Just so you guys know, I will talk forever. So I will pause for a minute and see if anybody has any questions. I see extra people join.
Kassie, hi, it's Dee. So what about the clients who have co-occurring mental health problems, which would probably be most of the women there? So do you want to talk a little bit about that?
Yeah, absolutely. So yes, I don't have the exact amount in front of me. I think we're around 92% of our clients have co-occurring disorders. Often because they're kind of lacking connection to the end services, they may not have an official diagnosis, but that's generally something we will work through them with, because you can have all the addiction counseling and treatment you want, but if you're not working on maybe the root cause of those mental health issues that most people are using drugs to help with, it's really difficult. In the state of Washington, although we have a lot of really great resources, they're extremely limited, and they are not made in a way that accessing them is realistic for people. I can tell you in Thurston County, we have 1 or 2 behavioral health places that will take, state medical, which is what most of our clients have. And in order to get a intake, you have to show up. You have to hope that you get in. You sit and wait for hours. Sometimes you won't get in. Now, if you've got someone who's got a lot of trauma and substance use that's really, really, excuse me, difficult to do. Not to mention, most of our clients don't have transportation. I don't know if any of you have ridden public transportation in the last 5 years. It's confusing. So those are things that we do with our clients, because we don't just say, here's a bus pass, go get on the bus, right? That's not helpful. So we'll say, you know what, I don't know that bus route either, but let's go write it together until you know that you're good. So really, co-occurring disorder, the mental health is such a huge, huge part of our moms struggling with addiction. We really say our case managers specifically, we're service providers, but we're not providing the service, right? So we call ourselves the experts at finding the experts. I am not a mental health counselor, but I'm going to get you connected to one. I am not, a housing case manager, but I know what we need to do to get you one. So really our goal is to be there to help them access those services that are often very difficult to access. So our case managers are working really closely with the clients and building that relationship. The second part of that, of their job, is really to work with the providers. Sometimes we have to PCAP providers, just like we PCAP clients sometimes, because often people are tired, they're overworked, turnover is insane. It's a new person every time you go there. People get cranky at you. I was sitting at DSHS this morning for 2.5 hours with somebody who just needed to sign an ROI. It is exhausting. And so for us to have, just the empathy and the unconditional positive regard for our clients, we try really hard to make sure we have that for the providers as well, because generally they're not, they're struggling with people who are struggling. It's not an easy job. So we try to make the providers, the social workers, the guardian ad litems, the CASAs, really we want to show up and we want them to be like, oh, thank God PCAP's here. They're going to help us. Our job is really to help everybody else's job be a little bit easier. We can provide transportation for our clients. We have some minimal resources on hand specifically for clients who are in PCAP, but really our ongoing community connections to mental health providers, the treatment facilities, inpatient. Generally, we have a little bit easier of ability to get clients into services a little bit faster. We also, so my site specifically, Thurston, Mason, and Lewis County, we're hosted at Family Education and Support Services. So just being there, we have access to a ton of resources, from parenting classes, anybody who has to do Consider the Children or impacted domestic violence, our organization does those. So we can do things like scholarships, because none of this is cheap and not everything is covered. So there's really a lot of benefits to us working with them. I will say, Dee, based on, the co-occurring disorders, it's just, there's just not enough providers. There's just not. It can take months. And if you have a client who's all of a sudden, just delivered a baby has been removed from you at birth, you're still in the hospital. Not only are you already have all of this trauma and mental health and addiction that you're carrying, the act of just removing baby from mom is trauma in itself for both of them. I'm absolutely not saying that there aren't instances that it is what is needed to happen, But we also now really have a lot more evidence that just being able to physically hold that skin to skin contact, eat, sleep, console, all of those things with mom, even if we don't want them to breastfeed because they're worried about what's in the system, just keeping them with mom, we are seeing better outcomes long-term in attachment and the ability for clients to make change. Our program specifically, the reason one of our enrollments is pregnant or postpartum up to 3 years. One, that first 3 years of the kiddo is really the most important development time. So we want to make sure that they have all of the supports they can have. But also, when a mom delivers, the amount of connection and hormones and desire for change in that moment is generally the highest we get, right? When you are delivering, there's just a level of connection and want for your baby that's usually the time when they say, okay, I'm ready. Let's do something right now. If baby's removed, we don't get connected to them till they're a year old. They haven't seen their kid. They're not doing visits. Kiddo's been in foster care. It's incredibly difficult to motivate those clients. So we try really hard to connect with moms before they deliver so we can be there when they deliver. Especially now as Washington state laws have been changing. And they've kind of, with House Bill 1227, are switching to this plan of safe care, which is a bumpy road. But ideally, we're getting connected before we get to that point so that they can really have the supports that they need. And really just, we're just there to help them access services and navigate services. So our primary aims really beyond building healthy families. And the reason that the state of Washington continues to fund our program, we are completely funded through the Healthcare Authority and a little bit through Washington State. Some of the marijuana tax money is partially what we are funded by. So our aim is to prevent future alcohol and drug exposed births. So that can look like getting mom connected to family planning. Maybe she's not ready to get clean, but let's get on family planning so we're not having any more babies right now that are going to be exposed, right? It might not be realistic to ask them to do everything at once. So let's work on mom, let's get on family planning of some sort, and not get pregnant right now. I will tell you, most of our moms who have kiddos, they want more kids. Whether or not it's realistic or something that, one of us might be like, why are you having another kid right now? You don't have housing. Those type of things. It doesn't really matter ultimately because they're going to do what they want to do. But what we can do is put in those harm reduction type of, services and get them connected. So basically, in order for us to prevent those substance exposed births, birth control, treatment. So if mom is not willing to go on birth control, is mom able to get sober? You would be amazed. It's always been a little odd that the amount of clients, when you talk to them about birth control, one, that have no idea really about birth control. If you think that you're not in, you're not going through high school, you're not kind of have those role models, you don't have a mom maybe who's teaching you about that. It's kind of mind-blowing, honestly. We have had clients in the past that just don't understand, right? You say, oh, they got you on birth control pills. Awesome. We've had clients who didn't know that that meant that they needed to take it orally because doctors don't really explain that to you. They assume. And it's It's just not something that if you have a cognitive delay or addiction issue that you really sit and critically think about. So realistically, we get funded because we save the state of Washington money. We keep kiddos out of foster care and with their families, and that can include relative care, rather than not, essentially. I don't have the most recent numbers that we have is, I think, 2013 was the last actual funding. Let me look if I can see the number. Savings, let's see. So our outcomes for cost savings for Washington State. So PCAP kiddos, so kids whose parents were in PCAP, had a shorter length of stay in foster care. So 3.8 months versus about 20 months. So in 2013, granted, you know, we're looking at about 4 months in foster care compared to the average, which was about 20 months. So our clients at intake, generally about 70% of them are on, you know, public assistance, TANF, EBT, Social Security, whatever that looks like for them. And over the 3 years, by the time they exit our program, the number was about 25% were still on assistance. So not only are we keeping kiddos out of foster care, we're getting people to be more self-sufficient and off of public assistance, thus include keeping, you know, those cost savings up. And we saw an increase of employment as their primary source of income. From about 6% of intake, about 6% of our clients have actual income, legal income, to about 25% at exit. So, you know, we started in 1990, so we're going on 25 years here. I think it'll be in April. So really, when we are looking at the amount of money that they're saving, this is why our program continues to expand. This is why our program is really expanding into other states. Like Dee said, we were both in Oklahoma, because they are starting the PCAP program over there. And that, Hank, sorry, hold on. Sorry about that. And then we also have like the reduced costs that we have of clients who are not in the criminal justice system. By reducing our involvement, many of our clients come in and have active criminal justice cases in some county, somewhere. It can be 20-year-old warrants. You know, often people would come anywhere from maybe having 1 or 2 warrants to, I think the most I've ever had a client was about 18 warrants in multiple counties. That is a scary thing to deal with. Nobody wants to go to court when you have that many warrants and you have a history of not showing up. Generally, at that point, you have some very upset judges. So beyond, for example, if someone were to go to be in jail long-term or actually incarcerated, we're looking at not only the cost for foster care, but also the cost of having to have a person incarcerated. Generally, we're able to really work through with our clients to get those warrants quashed and to show up to court and to work through that. So on average, about 88% of our clients who we work through the criminal justice system saves about $80,000 a person if we can keep them out of prison. Obviously, when I say keep them out, the clients are doing the work. They're the ones who are keeping themselves out, but we are helping them, we are guiding them. We're making sure that they get there. So 8 months to a year of like home monitoring is well, this number's I'm looking at is not right. Probably about $10,000. It's really expensive. But looking at like a medium security or the women's prison in Washington, we're looking about $100,000 a year for one person. So when we've got clients who
now it's telling me I have audio.
when we've got clients who are really up against all the odds, there's just a huge cost saving to the state for them to have a PCAP case manager. I'll pause.
Kassie,
Yeah.
Can I ask a question? Can you, because I know we're going to run out of time here, but I'd like to hear you talk a little bit about child safety issues and how the home visitors identify what they do in response to safety concerns and so forth. And so anything you can think about that would be helpful.
I will say, one of the perks of our program beyond being voluntary is that we are in the home. That means if your home is a tent in the homeless camp downtown, that's where we go because that's your home. If it is in a car, if it is on the street, if it's at the homeless shelter, that's where we go to meet you. So often, and I don't know, you guys are from very different counties. Often we see social workers who will do a walkthrough once, and not because they are neglectful, but time, really. We struggle to see the eyes on home, mom, and kiddos. We are absolutely not associated with the department, but we are mandated reporters. So unless I have an ROI, if I have a concern, I'm going to talk to mom about that. Our job is to see safety concerns before they're a safety concern. So if, there's, I don't know, old food or something that's on the floor, or piles of dirty laundry with a kiddo who's just barely crawling, lots of blankets in the crib, all of those things are things that we look for and are trained to see, and to teach them why that's a safety concern, why we need to fix it, and how to kind of keep that ongoing. So that being said, we are very, very transparent with our clients. We don't ever leave the house. We don't ever leave the house and go call CPS. If we see a problem, our job is to talk to our clients about them and say, let's call together and ask for help. Because if I'm building a relationship with somebody and I leave their home and see something and I don't talk to them about that, and I don't give them a chance to fix the problem, if it's not, a serious harm type problem, they're never going to trust me, which then makes my 3 years with them really not effective. So we are mandated reporters. We do immediately report any sort of, serious harm, anything like that. And if we have an ROI from the client and they're like, hey, anytime my social worker calls, you can tell them how many times we saw each other, tell them how many times, you saw the kiddo, or checked on them here, we will do that. But we don't disclose information unless it fits into that mandated reporter kind of area, or we have an ROI. And again, that is really just because our model is relational based. The only way people change and work through change is to have some trust in somebody. And often most of our clients have never had a person that they trust ever. They never have someone who shows up over and over again. One of the really unique things about our program specifically is that if you relapse, you don't get kicked out, right? But if you disappear, if you stop texting us back, you stop calling, kiddo got moved home and it's been a couple months and we haven't heard from you, we show up. It is a priority. We want to see your face. We want to make sure you're safe. We want to make sure baby's safe. We want to make sure that you're, not putting yourself in any situations. And I'll tell you, I mean, people who struggle with addiction, they go through phones like no other. They get lost, they get stolen. We don't have minutes. They move a lot. They really lose contact with family members very easily, right? If someone has pushed you over your limit and you put that boundary up. So generally, really, our clients are very, very alone a lot of the time. And they've never had somebody show up, right? As soon as someone relapses, everybody kind of shrugged their shoulders and said, well, okay, we knew that was going to happen, and gives up, right? So we don't. You're stuck with us unless our client physically calls me, the director, and says, Kassie, I don't want to be in PCAP anymore. They get through my spiel about why they want to stay in PCAP and actually tell me, don't ever come to my house again. They're pretty much stuck with us for those full 3 years. We continue to show up. We continue to, text, call, knock on doors. So that part specifically, because we're transporting, our clients will be like, oh, drop me off here, right? We make mental notes and we go back. We have tracing logs anywhere, phone calls they've called from, friends that we've randomly met, places we drop them off at, places we pick them up at, because those are generally places that they're going to go to again. So that being said, we have a very efficient way of really keeping track of our clients to make sure that our clients and the kiddos are maintaining safety, and that, they have some sort of connection. I have spent hours upon hours walking homeless trails in Mason County looking for somebody who might be there. Social workers are overworked. They're understaffed. They don't have time to do that. And probably, I don't know that their supervisors would really let them do that. There is a type of risk involved, right, in doing that generally that's not going to happen. So because we have really the freedom that we have in our program to support moms unconditionally, we can do those things. So when we are seeing, potential ongoing risks for the kiddos in the home, or even just, if we're doing like overnights for the first time, working towards getting reunified, all of those things, we can really be there with mom in a supportive way that is not there to judge them, not there to tell them what to do, but to make sure that they're safe, make sure they're learning how to keep their kiddos safe, and that they have somebody that they know is not going to judge them. I would rather have a client call me and say, Kassie, I'm going to relapse. Okay, so where is baby right now? Who's with baby? What are you going to do? Let's make a safety plan. Preferably, let's not relapse. Can I come over right now? Let's go for a walk. So because we have very small caseloads comparatively, most of our case managers have about 16 to 20 clients. Whereas social workers have, I don't know, I've heard everywhere from 50 to 200 clients at once. It's insane. We really have the ability to be hands-on and have some immediate response if our clients reach out to us in that capacity. Does that kind of answer your question a little bit, Dee?
Yeah, it's such a big subject, so
I know it is.
Let's give other people a chance to ask questions or make comments there.
I just wanted to follow up on that. So are your PCAP workers able to be named in DCYF safety plans as like part of the safety plan?
So we can certainly be a voluntary service. Our case managers, however, are not responsible for the social worker's job. We make that very clear. We are mandated reporters. We will do what we need to do. However, If it's not a mandated report, we do not report to DCYF.
And
Does
then
that kind of,
it
or you
does.
say, yeah, so we've gone through this with the plan of safe care a lot of times. They're saying, okay, we want to send baby home, but mom needs somebody there 24/7 to have eyes, right, for the next 2 weeks. We have definitely had situations where they want us to be that person. And we've had to put some really clear boundaries. We certainly can help. We will have times that we're showing up. You know, we will do everything we can, but we cannot be the primary, you know, safety or eyes on kiddo. It's one, not realistic for somebody who has any other clients to be able to spend that much time. So we certainly want to be in that kind of plan of safe care as a resource and ongoing support, but we are not the primary, you know, safety measure that often the department's looking for, right? They're usually like, well, do you have a family member who will stay with you for the next
Sure.
2 weeks? Do you have, you know, and do you have somebody who's going to be able to watch the baby while you sleep? Like, well, other people need to sleep also. We're kind of in this weird middle stage with the plans of safe care that they don't always make sense. No new mom is awake 24/7. They're just not. So if it is something like that, it becomes very difficult. That being said, we are there to support them. We can help get them connected to respite care or in-home care or anything like that that they might need, you know, very easily to say, you know, oh, you need me to bring you some groceries, you need some diapers, things like that. And we are there frequently, especially in the beginning, if the client wants us to. Because we're not the department and we're voluntary, you know, we are highly trained individuals. You have to have a minimum of a bachelor's degree to be a case manager. That being said, most people have master's degree, but they're not all degrees in social work. Some is mental health, some is counseling. It's really just kind of all over the place. And in that time, you know, we are highly educated. We know what we're doing, but we don't have the legal ability or right, or do we think it would be very effective if we just walked in their home, right? So we're not going to say legally you have to let us in. Ideally, we have the relationship with them and they let us in.
How do you feel about our advocates or guardians ad litem in general contacting your workers and just saying, hey, what do you know about the case? How do you feel about that kind of information sharing between, you know, coming at it from the kids' perspective too?
Right.
How do you feel about being able to kind of provide answers or maybe even kind of like, I don't want to say case plan, but kind of develop a kind of plan for working with the family? How do you feel about
Absolutely. You know, it's very dependent, I would say, on the client and on, you know, in the CASA or the GAL. Say everybody who works in social services sometimes has a little bit of I know, I mean, even I do it. We want to fix everything, right? We want to save everything. We know what you need to do, just do this. Like, why aren't you doing this? You know what you need to do. So sometimes some of our social workers or CASAs or guardian ad litems can come off a little bit strong, and it's very difficult to get our clients to kind of come to the conclusion that you are there to help them and the kiddo and not just making their life harder. So we really try to educate our clients in your guys' role, what is and isn't acceptable. We often have social workers or really anybody that sometimes oversteps because they think they could fix something, or, you know, just, you don't need to do that, do this. So that being said, if we have an ROI, if we have had the chance to talk to our client, and they are on board 100%, we will come to any sort of meetings. We'll make an extra sit down. Let's make a plan. We go to FTDM, so we go to court dates. You know, I would say we have a pretty good relationship with our GALs in Thurston County and the CASAs out in Mason County.
One of the things, and
So-
I'll just to be kind of be
Yeah.
transparent and honest, because one of the things that we'll hear about PCAP is that you guys are enabling the client.
Mhm.
Like you're not really fixing it. And so I think there's sometimes a little bit of that.
Yep.
How do you respond to those kinds of claims or those types of arguments?
Yeah. So, like I said in the beginning, absolutely. In the first year, it looks like we're enabling them. If you have a client who doesn't know how to read, it's never been taught how to do things, that's what you do, right? When you have children and they're developing in those years, the most important thing to do is you show them how to do it first. You tell them that that is hot, right? They're still going to touch it. They're still going to generally have to learn what that means. So when we have adults who are cognitively not developed in the same way that someone who doesn't have the trauma and addiction that many people have, it's the only way for people to make change. You can't just tell somebody to do something. You have to walk them through it. You have to role model for them, just like you do for children. And I don't want to say that, you know, I have plenty of clients who come in with bachelor's degree and master's degree and are very highly intelligent. This isn't 100% across the board, but really probably about 80% of them have not learned basic life skills. You know, we have so many clients that have such tragic childhoods, you know, when you are having your parents get you high at 8 years old and selling you, you learn a different way to survive. You don't know other ways. So yes, absolutely, that first year, it looks like enabling, but that first year is us building the relationship, having the rapport with them, and showing them that we care enough to show up. So by that second year, they can start learning how to do it by themselves. We have this weird, you know, oh, a habit can be changed in 90 days. That doesn't mean the desire for the habit goes away. That doesn't mean that you understand the change. You know, there's so many levels of addiction. If anybody's ever tried to be on a diet and then be like, don't ever eat a candy bar again, except for candy and sugar does affect your brain, imagine that times a million if you're using fentanyl. It is the same thing. Your brain tells you you need it. You're going to die without it. And you don't have the coping skills or the resources or the ability to find a way to get through that. So, you know, it may look like enabling, but that's why we're here. Let us do that so you don't have to. Let us teach them. Let us give them rides. All of those things that we have with that one-on-one time with them is so important. And that is why our program is 3 years long. Honestly, if it could be longer, I would say make it longer. But you're not going to find a 3-year program in the state of Washington that is not punitive, that is going to be actually role modeling anybody to make change in their life long term. So, and I would say
And I
just
know we're running out of time, but I'd like to
Yes.
hear, you know, just briefly what you think about a public policy, like what kind of resource would be of greatest assistance both to your case managers and to the families that you deal with?
as far as public policy and
Yeah,
like the
I mean,
changes.
what would you like to see more of? I mean, what would you like to see the legislature fund in terms of helping services and so forth?
Oh man. I mean, we need more treatment facilities and we need more behavioral health facilities. If someone says they're ready to go to treatment, but then it's like, well, it's going to be about 3 weeks before there's a bed for you. That's not generally how change happens. In 3 weeks, they might not be in that same contemplation. At the same time, it's great to get somebody into a treatment facility, but if we're not connecting them to mental health and we're not helping them solve the core problems that is feeding the addiction, then it doesn't matter what we're doing. Housing, obviously, that's kind of just an ongoing crisis for the whole state right now. Childcare, it's impossible to get childcare nowadays. You're on wait lists. So, which means it's really difficult for you to go to all of your classes or do your UAs or really anything. And honestly, the biggest thing, especially with what we're seeing in the shift with the new House bills coming and the plans of safe care, we are seeing an incredible drop in dependencies, at least in our counties, which there's a part of you that goes, wow, awesome. But that doesn't mean the problem goes away just because we're not opening dependencies. Generally, when a dependency opens, those clients are getting access to services. They're getting them a little bit easier. There is some funds that DCYF has for gas cards or vouchers or clothes for the kiddos. So now, basically, all of that is gone for those clients who are not getting an actual dependency. You get volunteer services or you do a FAR case, you'll get a little bit if you know what to ask for. But generally, they're being saying, oh, there's no funding for that. You don't have a dependency. So they are really, really cutting off a huge amount of resources to families that are really in need. I think that money that was there for the department needs to be reallocated to services so clients can continue to access them. It's difficult. I mean, we used to have really good, we could call a social worker and be like, hey, we need a car seat. Those used to be fairly easy type things to get, and they're just not anymore. So I think that funding being reallocated in some fashion or moving it, from dependency to voluntary cases, is going to be hugely important. There's just a huge gap now. There's all this weight has shifted to community, service agencies and voluntary services, but the money didn't shift with it. So now we have an overload sitting over here of people who don't have the resources that they would when they were involved with the state.
It just seems like it's just a crazy thing. I mean, why would a state reduce dependencies in foster care and not increase resources at the same time? What would be the logic of that? I mean, it's just a mind-boggling piece of stupidity, it seems like, or maybe it's something even worse than that. I mean, it's just...
It really is. And, some of the frustrating thing is, our Keeping Families Together Act. That can be kinship. That can be, family doesn't necessarily just have to be mom. Doesn't have to just be dad. We don't have to go into foster care, but you can't also expect a 70-year-old retired person to all of a sudden have the ability and the funds to take care of children. That is not what they planned for. It's not what they really have money or resources for. And, we have a kinship program at FES. Of course, we do everything we can, but that funding of, oh, we're not sending people to foster care, that funding is not reallocated either. And that's, for me, the hardest thing to understand is like, it's not keep mom and baby together, is right, keep families together. We want to keep them intact. We want to keep the connection. And we want to keep them out of foster care. Great. We need to allocate money and services to those families so that they're getting help that they need.
Kassie, I have so many follow-up ideas that I need to discuss with you about this. And I think the climate is getting right. I think they realized they did an overcorrection with Keeping Families Together, and you started to see that this year. But you're right, because we're seeing it too. We're seeing all these families that need that. There's that gap. There's that shadow foster care system of where it's just the department kind of messing with those families, kind of throwing out little things here and there, but not really helping the families all the way that you do. get all the help that you do get when you've got like
Yeah.
an attorney, you've got people like you've got us kind of poking around too, like all of those things that just don't happen when it's just the department working with these families. So
Yeah. I know that I will stay and happily answer any questions if anybody has them. I also know that we're out of time. I'm also happy to come back at any point in time. I'm, you know, been doing this for quite some time, very, very passionate about it. Our site specifically is the largest in the state of Washington. And we really are just trying to get it out there that we're here to help, you know.
This just seems like a really big subject, and I know what Ryan says. I have a lot more questions too. So what about thinking about in a month or two, maybe doing a follow-up? Maybe we can discuss here further and maybe just continue the discussion either next month or the month after.
Absolutely. You let me know. Fridays are actually my easiest days. So you let me know when and where, and I'll be there. And if I don't know if there's questions or something that you can send me beforehand, and I can be a little bit more prepared, or anything along those lines, I'm happy. And I really want the connection. And if any of you guys aren't connected with the PCAP in your county, I can send out a master list of all of the phone numbers for the PCAP in your county, but you all have them. And I would just recommend using them. You can call them and say who you are. They will schedule a time to meet with you if you need. They will get you the resources you might need to make referrals. Really just go out of the way to make it easy for you guys to connect.
Ryan, what about setting up an idea that if folks have questions or comments, they can send them to you, and then before we have the next session, you can send them on to Kassie?
I would love to do that. And I'd also like to kind of put that out to our program staff as well, like the program managers, because I think they may have some additional questions. They just can't always make these trainings. So yeah, I think maybe that might be our next step too, is just kind of looking at kind of some kind of joint training thing where everybody gets to ask questions and go from there.
Yeah.
So love that idea.
Right.
Well, thank you so much for having me. And again, I'm sorry. I always try to give the disclaimer. I can talk about this forever. The program is pretty amazing to see the changes we see. So it's one of those things to be pretty passionate about.
Well, thanks so much for doing this. And I'm a big fan of your program and have been for a long time. And so I'd really like to see it expanded and figure out how to make all this work there. So
Great. Thank you so much.
Thanks,
Yeah.
everyone.